Welcome to today's MESUD Community Learning Community PMP webinar. Today we'll be hearing from Dr. Stephen Martin on chronic pain in America, past and present. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please place all questions in the Q&A function. And now I'd like to give a quick introduction to our speaker today. A graduate of Williams College, Harvard Graduate School of Education, Harvard Medical School, and residency in family medicine at Boston University, Dr. Martin was the National Health Service Scholar for Rural Community Health Center and a Federal Prison Medical Center. He has since worked for nearly 15 years at the Barr Family Health Center and in rural central Massachusetts, where he is the medical director of its office-based addiction treatment program and a professor of family medicine and community health at UMass Chan Medical School. He is also the medical director for research, education, and quality for Boulder Care, a company providing telehealth-only care for substance use disorders, primarily for patients with Medicaid. And with that, I will hand it off to Dr. Martin. Thank you all for being here today.
Thank you for that terrific introduction and time. I'm saying, Bethany, that your background of Maine is even far more spellbinding than mine of the berry. I know, cannot compete, but at least they're both in full bloom, not with the snow that we actually have on the ground here in Western Massachusetts. But I'm grateful to be associated with anything Maine, and certainly with for time with you here today. For a subject that will likely never go out of fashion, which is how to help people with chronic pain and do it well. And it's an area that I have learned a great deal from patients about, from colleagues about, from making mistakes and learning from those. And I'm grateful to share with you some ideas that I hope are helpful. And also a perspective that can be helpful as well. And look forward to your comments and any discussion that you'd like to have after the presentation. So I'm just going to share my slides here. And like chronic pain itself, I want to recognize, here we go, sorry. This is one of my classic stop share things. Excuse me, sorry, almost there. Here we are. I apologize. And yet again, here we go. Okay, can everyone see my slides okay? Looks like you probably can, I hope.
Yes, they're good.
Yeah. So this is sort of an intentionally unsettling image, and you may know this person's appearance. This is Frida Kahlo, an extraordinary Mexican painter who represented her pain with not just this painting, but with many others. And I share it because I think often in either outpatient or inpatient settings, we're not as accustomed to really getting at the kind of existential and like sort of ego dystonic and difficult to survive pain that many of our patients are experiencing. And I thought her image here, and we'll return to it, really drives home that whatever we may see on the outside of someone, this painting is called The Broken Column for a reason. And she represents it graphically. So I have no related disclosures, as mentioned, and our goals are here: epidemiology of chronic pain and patient experiences, and the impact of national recommendations and the advent of revised recommendations, and mostly, though, helpful approaches, I hope, for caring in caring for people, with an extra care in the sentence. Sorry about that. So I'm actually going to start with sort of some of the more recent history, and then we'll look back a little bit further and then look to our present day. But a colleague of mine at the University of Alabama, Stefan Cortez, published this cartoon as part of an article in 2017, after the CDC guidance was released in 2016. And I thought it was a very moving representation, having taken care of both people with opioid use disorder now for about 20 years, and also people with chronic pain for the same period of time. And for me and many others, it explored the dissonance that seemed to come with the guidance at that time. In that here I am as a clinician telling the patient that too many people are dying and the situation is out of control, but we have to stop your opioid prescription. And a patient of any sort, size, shape, age saying, but what did I do? And unfortunately, we saw this dissonance sort of reach a troublesome head shortly after the guidance was released. What Stefan and I and others were concerned about was that, as seen in this pie chart from 2013, 2014, but published during the time contemporaneously with the CDC guidance, was that upwards of 80% of prescriptions that people were using for opioid misuse were not from a doctor, their doctor. They were from a doctor. They were bought from a friend. They were from a friend for free. Many of them were shuttled on the OxyContin Express from Florida up through Appalachia. But what we see here is 22% of people having their prescription from one doctor, 3.1% from more than one doctor. The issue here is that most people suffering from opioid addiction at that time were not getting a direct prescribed medication from a doctor. And that meant that most of the people in this preceding cartoon had nothing to do with the medications that were going to other people for their misuse and substance use disorder. And placed on top of that is that people do not readily stop opioids. And the natural history of opioid use disorder and opioid dependence, when people do not have access to ongoing safe supply of opioids, the natural history is to use an unsafe supply. And again, the natural history, the predominant of patients die from that disease of opioid use disorder. So what we see here is from between peak of 2010 to today, that opioid prescribing levels have reached 2000 levels and now even lower than this into 1998 levels. And so we've withdrawn a tremendous amount of supply, a safe supply, to people who had prescriptions. And it turns out that that does not put the toothpaste back in the tube. And what we're left with is an increasingly accelerating overdose rate during that time, and the use of more potent synthetics since 2013 or so. We're from roughly the same geography, and so my sense is that Maine has had very similar to Massachusetts, where fentanyl appeared in 2013, 2014, and has completely overcome the heroin supply since. In 2019, some of this was starting to circulate and surface that, however things turned out, the guidance met federal officials, state officials, health services, physicians, clinicians of all sorts, and even state law, and led to a drastic reduction, as we just saw in the preceding graph. And so in 2019, the Department of Health and Human Services actually rapidly issued somewhat of a correction. And just to make crystal clear that the first assessment in this flow chart is to assess the benefits and risks of continuing opioids, and if the benefits continue to outweigh the risks, to document this and continue to reevaluate and continue the treatment. So what happened instead was that many patients who may have been having their benefits outweigh risks were instead forced to come off their opioids either rapidly or more slowly. When that happened, when people were discontinued opioids, this is from a New England Journal article 2 years ago, people turned to heroin and other illicit substances, opioids. People's emergency department and rates accelerated. People had additional increased mental health crises and overdose events compared with baseline, and death from suicide actually increased proportionate to the amount of time they had been on opioids prior to discontinuation. Just this year, we found that patients who are decreasing their long-term opioid treatment are at higher risk for developing a new alcohol-related condition. Because my sense is what we forgot as we were making these changes is that, as Kahlo shows in this image, that for many people, pain was why they were using medication in the first place. And it turns out that pain doesn't go away necessarily when you stop a medication. Kahlo actually herself was in this tremendous amount of pain because of a bus accident she sustained at age 18. And you can see her here actually painting from her bed, where she had incredible talent and also this assistance to do so. It mentions in the last sentence that she spent the rest of her life trying to recover from this trauma. And actually, if you look at all photographs of her during her adult years, she wears almost always a full dress past her ankles and feet. Her legs had been really disfigured with the accident, and she actually died from sepsis due to non-viable leg tissue that she did not want to have amputated. So chronic pain asks, it asks a lot of a person. It acts over the course often of years or decades. And it's one of the first reasons why medicine was conceived in the first place, millennia ago. Here's a gentleman during the Civil War, the United States Civil War, when morphine became more predominant as a possible treatment, and the hypodermic needle was also more available. And I think we can see here reasons why pain control was seen as humane and necessary. Many people during the Civil War and after, the demographics shifted a bit, but there was the development of what was called morphinism, which was a continued dependence on morphine, which is what one would expect with dependence on an opioid in this case. And morphinism has sort of changed into heroin dependence and now even fentanyl dependence. All going back to pain. I mean, most people, when they start, even today, most people using fentanyl in British Columbia report that they're using it for pain. 70% of people are using that continuous fentanyl. And so I think a more grown-up look personally of why part of our epidemic of harm with opioids is that people have pain, and that pain can be relentless. And if you or your loved ones have ever experienced a sense of pain that was unending, you get a sense quickly of what you would do to try to make it stop. But pain has always been part of the human condition, and here we have the word that shall not be spoken is actually the word suffering, which is different than pain and has a different connotation, and one that I hope we could discuss a bit here today. But the ideas that I take away from this sort of collage is one, as a clinician, really leaning into and being with someone, bearing witness to their suffering is an important part of care. That even Maimonides, not even Maimonides set a set of principles that that's who we are to see in the patient, as someone in pain. The pain treatment is actually a moral and ethical imperative. And lastly, the second box, that most of our analgesics don't work. In fact, many people absolutely do not like opioids. And that's why they were one reason why many of them were available from prescriptions that people didn't use. They didn't find them interesting or euphoric. They actually found themselves nauseous or feeling badly on them. So once we find analgesic success of some sort, that's what's to be pursued. And if it helps someone live their life more fully and with greater greater sense of agency and happiness, then that's a pretty darn good thing to have happen from medicine. So some reflections. I'd love to hear your reflections also, for sure, and that's what I'll be writing. I've got a pen and paper here, but pain is, there isn't an ICD-9 code or 10 code for existential concerns, but that's actually the way that many people think of pain in interviews and surveys, is that this is a sort of a threat to their integrity, a threat to their way of life, a threat to their relationships. That we, in all, whether it's a lack of education during training, I have to think that even if we had more training, we still wouldn't be that great at it with 12 to 15-minute visits. They're not very conducive to the kind of work this requires. It's more conducive to maybe a sore throat that is relatively uncomplicated. But in this case, almost all chronic pain is going to involve complication and time. We need time to do that well. A lot of our effect comes from longitudinal, caring, trusting relationships. And if you have a chance to speak with people about why they don't seek the health system, it's because it becomes too unpredictable as to what any given clinician will do. And it feels like a shot in the dark that they will actually get help from the next stage or referral. But we can offer absolutely this kind of unconditional alliance with a patient, even though we have to come to share decision or as to what we think would be most helpful, and that what we can support as their clinician. And I'm super not a fan of, I love basic science. I taught chemistry and biology. I think it's like the best thing ever is science. And yet science does not help us with existential concerns. And science mostly doesn't really help us a lot with someone's experience. And so we'll allude to sort of types of pain, but the type of pain someone is experiencing is really their pain. And I think putting labels on things like nociceptive or neuropathic or really belies the actual bespoke experience that someone has and is unique to them. I think what was also missed in the CDC guidance was that the experience of chronic pain itself leads to a 10-year loss of life expectancy. And pain is not like squeezing a balloon and then the air just magically comes out. The air is still in the balloon. And ongoing pain does not happen in a vacuum of available lethal substances. And people have used alcohol, cocaine, opioids for millennia. Some have used it for euphoria, and but many people use them for pain. And as I mentioned earlier, that's still the case for people regularly using fentanyl in Vancouver. They are not using it for euphoria. They're using it for pain and may have started that way as well. So I think ways that we can think about individualizing chronic pain treatment, someone's affect and the way that their pain is affecting them is they sort of the one sort of way of thinking of pain as compared with suffering. So someone can have pain, but suffering is sort of the affective existential experience that happens as a result, perhaps, of pain. And someone can be suffering from grief, for example, which is a type of pain that we consider to be a normal part of the, again, human condition. But in this case, chronic pain certainly has an effect on people's affect. And the reverse, if their affect is improved, it often makes their pain perhaps seem less difficult. I mentioned this idea of pursuing analgesic success, even when you expect your number needed to treat is not going to be one. And that listening to the patient and iterating is, I've looked very carefully, can't find a better way of approaching than that. I do think I've been really influenced by Boston University's Scope of Pain, and highly recommend that website and the training that happens there. And I'll share some of the curricular aspects that they lend to these kinds of clinical decisions. I do think it's worth knowing if something helped someone in the past, and even if especially if they said, opioids helped me, but I got them from a friend for 2 years, then they moved and I haven't had them, and now I'm really desperate. Or to find out what's bothering them the most, which may be different now today than it was 2 years ago. And really having that sense of understanding that as much as we can of their experience and what is most germane to them today. So I'm going to say the same thing in two different ways. One is sort of as I think a support for ourselves being part of a person's care effect. And it'd be misleading to say that the experience someone has with their clinician isn't relevant. It's highly relevant to how they feel about their lives, and highly relevant to their experiences and improvement in their lives. And at the same time, I want to be careful about, how we represent that kind of caring. So this study from both Dartmouth, Haifa, Israel, and Heidelberg, Germany, came out just earlier this year, and a use of natural language processing that I thought was actually incredibly illuminating. So they fed qualitative studies, hundreds of qualitative studies, into an algorithm that looked at people's descriptions of pain, and were able to create a set of nomenclature and categories that I think I found really helpful. So pain, we often think of as being in this, second category in the middle, physical. But it turns out that people actually have a much more prevalent sense of existential concerns and meaning in their life and dissatisfaction with their life than their immediate physical concerns. And in fact, under physical in this top left, 2 of those lines are blanked out because it turned out that they didn't turn out to be as relevant as the researchers initially thought. So if you look at about 3 o'clock on this figure on the left, everything from there down are spiritual concerns. And again, American healthcare, that's not really our strong suit necessarily, but it turns out that it has a lot to do with why people are hurting and suffering. And I think sort of naming these types of suffering for ourselves and for our patients, has a way of helping our thinking and helping be more precise about the concerns people have and would need to be addressed. This is somewhat of a self-selected group of studies, but it's not just that there are the categories. This spider plot, my favorite kind of plot, because I get to say the word spider. But if you look at the very top at noon, the most mentioned in these qualitative studies are low quality of life that's effective, existential concerns, their experience social concerns, threat, all before physical. And I just think that we often come with, understandably, a sense of pain that's immediately related to physical uh, uh, precedent or cause. But the part that I have always found very difficult to understand, but is almost it's just surreal, but all chronic pain is coming from our brains. And whatever stimuli happened long ago in a certain area uh, doesn't really exist in the same way it did initially. But the way that we've wired since then, not necessarily locally, but really within the spinal cord and within the brain, is where that experience is coming from. This is from the scope of pain uh, curriculum that I mentioned earlier, and I think about this all the time. I've tried to get even like a temporary tattoo, but I'm not sure I could read it like one of those, like I think of Tom Brady reading his arm, trying to figure out which play to use next. But in this case, the idea is thinking about function and well-being, quality of life, and reducing pain. And recognizing that studies on opioids were criticized because they were less than 12 months, but most every study on pain is less than 12 weeks. And most types of pain and interventions have costs or risks. My mother-in-law had terrible arthritis and took NSAIDs for many years and presented to the ER one evening with a perforated gastric ulcer and would have died without the help of an incredibly talented rural surgeon. People here in Massachusetts and elsewhere were affected by fungal infection from their nerve blocks and epidural injections that were contaminated, and 17 people in Massachusetts died. It's hard to find something that doesn't have risks that need to be balanced. Some of those risks are certainly going to be of less magnitude. I think, again, we do a terrible job in healthcare. I put here in orange, sort of in the middle area, I put in osteopathic manipulation treatment, which my colleagues do at Berry. I wish I knew how to do. It's really been a type of treatment, a manipulative treatment that patients find really moving and really relieving of their symptoms, and they're overwhelmed with the demand for it. I do think that we're missing tremendously on massage or medical massage in allopathic healthcare. Turns out that if you're in Canada, the nurses in Canada by contract have nearly unlimited massage as part of their contract. And they do it for a good reason. They're very smart. It is actually, very therapeutic. And yet that's really something that's not paid for. We're much better at paying for injections of things that have pretty shaky evidence, rather than giving people a menu of options, and letting them sort of put together a set of therapeutics that they would find most helpful. So this is the flip side, though, of being a placebo or a support, is that we have to be careful not to lose our way and become trite. And this is just from earlier this year in September. Things people have yelled down to me: a person trapped in a well, alone at the bottom of a well. And these have become almost farcical. Are you sure you're really trapped? You're not really that trapped. I was trapped, but the well just went away when I got more sleep every night, ate protein at breakfast, and had a cold plunge. Why don't you try gratitude journaling? Have you tried getting out once in a while with your luxury sedan? Nobody's going to want to be around you if you keep dwelling on this, and maybe you could learn resilience from this experience. And certainly, lastly, have you tried yoga? So I do think that the uniqueness of someone's pain experience also lends itself to some uniqueness in determining what's there to best help them, but to be cautious about telling them a story that really doesn't fit their experience, and also somewhat gaslighting their experience with sort of superficial means of interpreting it and offering help. Before the CDC guidance, Relieving Pain in America came out, which is an Institute of Medicine report from 2011, and I thought it was I think it's very transparent and authentic in its way of demonstrating the profundity and the difficulty people have with pain. And that I like this sentence or phrase: it has little deeming or romantic quality. Uh, and the story of pain can be transformative and blunt the human values that we really want to express during our lives. These are some common sources of chronic pain. I realized in looking at this, as you may also, that I think I've treated each of these many times. And it's striking now in 2024 that there's a significant amount of regret about, for example, people with sickle cell anemia and sickle cell disease not being treated for pain. And cancer is on this list as well. But I'd be hard pressed to say that if someone has life expectancy that is reduced by 10 years by virtue of having chronic pain already, I personally don't understand sort of the taxonomy of what makes one type of pain more legitimate than another. So I mentioned there's pathophysiology that we could look at. Here's our brain. Here's the classic sort of neural pathways that are affected. I can't see inside my brain or my patient's brain. I think it's useful maybe to know that this is happening. Again, with all full respect, there aren't direct actions I can take at the brain level, even though we often tell ourselves that with basic science understanding. We really, to my knowledge, we really don't have much of an understanding, beginning with SSRIs, as to the changes we're making at the brain level. But we do know the changes we're making for someone at their lived experience level. And here you can have two different patients, A and B. They both have same levels of pain that they report, but their experience, as we saw earlier, can change from being very physical to being an environmental stressor. It turns out, shockingly, that my patient's pain goes up when their housing is unstable. And it gets better when their housing is stable. And yet that's not, for me as a doctor to affect very much. But environmental stressors and psychosocial stressors are highly relevant to treatment of pain, and especially chronic pain. So these quotes over the generations have a lot of merit to them, I think, and get to the idea that we're not treating the disease, we're treating the person who has this disease or this condition or who is suffering. And yet I don't think that's been held up in recent times with the kind of merit that it actually has. So I was going to share with you a few patients, and then certainly get to some discussion or hear your thoughts on helping people. But these are folks I take care of and have for several years. And orange is sort of the overall thumbnail sketch. This is a lady in her mid 40s. She has some of the most severe rheumatoid arthritis I've ever seen. She's had elbow replacements now and is in a wheelchair. She does have a personal care attendant. Her daughter was recently married in St. John. She's not, she doesn't have means of much at all, but there is some disposable income in the family, which actually matters quite a bit. And so these are the things that she really likes to help herself. She really likes the OMT I mentioned, the osteopathic manipulation treatment, and she is on a tumor necrosis factor inhibitor as well for her autoimmune disease. And the actual replacements themselves, have maybe limited her function somewhat in terms of range of motion, but they've also really mitigated her pain substantially. you can sort of see how that's different than a different patient, also in his 40s. This gentleman is, a long-term unemployed, really no close relationships, whose status post laminectomy, cervical laminectomy, and then a motor vehicle accident with a settlement pending, has been accepted for disability. And what we've worked to do over the years has been really structured follow-up, really supporting very much his ability to have stable housing and food on the table, working to help his anxiety, which is synonymous and interlaced with this experience, to be very aware, for me to be very aware of his housing and relationship status. He's also on a fentanyl patch and oxycodone. He's on clonazepam and gabapentin. And I have done deep dives on these combinations and have the data I'm happy to share. But when the FDA put its black box warning on, for example, opioids and benzodiazepines, it turns out that most of the studies they used, of the 6 studies, were times that patients were not taking their own medication. And so it is a very different outcome and circumstance when a person is taking their medication as prescribed month after month, are stable and their lives are improving, as compared with an epidemiologic study that finds that when people overdose, their toxicology studies show combinations of medications that may or may not have been theirs. And I think that difference it's disingenuous not to take note of that, and disingenuous to describe combinations as only risks and not potential benefits. This person also likes to sleep and does really much worse when the weather's cold. One more here, a couple more if it's okay. This is a patient with a high ACE score. She's in her mid-50s. She had multiple reconstructive surgeries in 1995 after trauma. Also has, as I mentioned earlier, above, with a high ACE score and sexual abuse history. She's on SSI. She lives with her 18-year-old daughter who had a tetralogy of Fallot and has had iterative surgeries. She was engaged at the time that I was writing this. Advocacy for her needs, including electricity, has been very helpful. We've tried pain centers. They haven't been that helpful. Unfortunately, we've lost a lot of multimodal pain centers over the last 2 decades. And in my experience, they're mostly all anesthesiology focused and procedure focused, which is not something that really helped her. I text with her a lot, and she lets me know if she needs something soon. And I found that to be that lack of uncertainty, or helping her uncertainty, has been really a relief for her, she says. She cares for her daughter. Now she cares for her granddaughter, who's exactly like her. It's exactly like, they look alike, they talk alike, they have the same really wonderful approach to life. So she has a multi-generational family. We've been working with plastic surgery on some remaining parts of her reconstruction. These are her medications. She came to me on these medicines, but as I mentioned earlier, my choice. She came to me over a decade ago. I could have stopped these. I could have titrated her down from these what were very high doses and still are. But as we saw earlier, it turns out tapering down is not like putting toothpaste, or it is like trying to put toothpaste back in the tube. That it's a very different set of outcomes that you can experience, a patient can experience, and we now have this data of substantial harm coming to people, including completed suicide, when tapering occurs without joint decision. If someone were edging or in a state where they were significantly overusing or had aspects of a use disorder, then I'm very grateful to be prescribing buprenorphine if needed. I'm grateful to have in our area a couple of terrific opioid treatment programs that have split dosing and take-home methadone that allow for methadone to help with pain as well. And again, she really likes to sleep. So the last one here before we reach the quarter of the hour. This is remediable pain, but it needs an intervention. This is a 44-year-old female. with right hip pain, but young enough that orthopedic care orthopedists were hesitant to do surgery because of her younger age, but she had a very difficult time bearing weight on her hip pain. She actually, in this case, had a history of hip dysplasia that rendered her hip virtually unusable at this age. So having advocacy with orthopod colleagues, a temporary use of oxycodone until her surgery was complete. And she is living a wonderfully normal life thanks to modern day ability to for joint replacement. It's really a miracle. There are others here, but I hope you just sort of get a flavor here. I don't mean to belabor the point, but every one of these patients is different, and their things that help them are different. In this patient at the very bottom, relationship work with her boyfriend, being cautious about dental pain being acute on chronic for her, lots of phone calls. And in the last case here, a patient of mine who's in his 70s with his long-term boyfriend who loves to hike and host parties and travel, but he does have chronic sciatica and uses oxycodone about 4 times a week, and continues to do exceptionally well. Just saw him last week. So really appreciate your time here together, and hope this has given in 45 minutes or less sort of a sense of how chronic pain comes to our practice with our patients, and how we can, I hope, make use of and leverage the healthcare system for what it can offer, which is quite a bit to people, as long as we don't use sort of the cog in a machine approach that can become too used to in modern day medicine. So thanks very much.